Hi, everyone. Thanks for joining this morning. Thank you for joining the DEIJ Task Force webinar series. This month, we're excited to introduce Aswita Tan-McGrory from the Disparities Solution Center in a webinar titled Applying an Equity Framework to Patient Safety Events and Root Cause Analysis. Go ahead and take us away, Aswita. Thank you.
Okay, thanks and welcome to what I hope would be sort of an interactive discussion. So at any time, I guess, raise your hand or chat in a question that you have. And let me just share my slides. All right, let me know if you can see this.
Yep, that works.
Okay, great. Okay. Let's see. All right, so just today, I was going to, and I just want to make sure I can see the chat. Okay. I was going to talk about sort of this bias discrimination pilot for patient safety events that we started, I think I want to say almost a year and a half ago. And then what are some of the current trends in the reports and what are some of the resources that we can provide? And this is really a discussion about accountability, making sure that we are held accountable for what happens within the hospital, but also what are some of the things that we're seeing in the report, sort of what is the culture on the floor. And then the goal here is also full transparency. So thinking about, how can we be transparent in the work that we do, and including sort of looking at quality metrics. So this is just a screenshot of the safety reporting system. We use RL Solutions. I'm not sure what safety report system you guys use, but we use RL Solutions, and this is sort of a screenshot of the note that went out when we rolled out this pilot. It's still happening, so I don't know, the pilot sort of started out as a pilot, but we actually sort of are continuing it. So I guess it's not really a pilot anymore, but it's really giving a note to let people know that there's now an option to submit concerns involving racism and discrimination that impacts patient care. So that piece is very important. It impacts patient care. And I'll talk a little bit more about, the difference in that versus like bias and discrimination from a colleague. That's more about sort of professional interaction that isn't about impacting patient care. So this is like what we rolled out. And, what we did is we built a tile, as you can see here in the top, just specifically for racism and discrimination, so people can file the report through that tile. But then also in each of these other tiles, there is the option of saying there is a concern for racism or discrimination in this case. So it's sort of threaded throughout the reporting system. And this is just a diagram to show you like how the cycle really happens. Is the employee files a safety report with a racism discrimination tag, and then our quality team sort of triages it to the department owner. So whether that's like GI or oncology, and then the department head, usually the quality head, investigates and then consults usually with myself or another staff member who is sort of has the quality and equity expert. And this is us again. And then we sort of think about what kind of resources do we provide based on the report that was filed by the employee. But I also like to sort of talk about like an informal channel. This is sort of the formal channel through RL Solutions, but there's also an informal channel where, people don't necessarily trust a system. So the employee or supervisor reaches out through informal channels, meaning I'll get an email directly with some concern from either an attending or a trainee or a nurse saying, I witnessed this and I'm really concerned. So there's both ways that we can sort of get this. And this informal channel really has to do about trust in the system, that it works, that this works, but also trust in like wanting to disclose this, but wanting to disclose it to somebody who you know it will be safe to disclose to. And that factors a lot in these sort of safety reports. Oh, so when we first started this, I looked at like their sort of, root cause analysis, timeline and checklist. And, I sort of inserted in the yellow sort of like, okay, here's what's going to change now that we're collecting racism and discrimination and bias. And, here in this step, this is just a whole checklist that they have. I'm just going to run through this because it just, the one thing that I did add in was sort of like, okay, if we look at something like, what are the ways that we can sort of think about this patient safety event in terms of from an equity lens, and really thinking about trauma-informed care approach, thinking about external context, so historical, cultural, language. It doesn't just happen within the medical setting, but there are other factors outside of our organization that influence the reporting of the patient safety event, sort of identifying what are some of the system barriers that may have contributed to this. And then counterfactual root cause analysis. I mean, I think some of us do this sort of in our head. If you change the gender or the race of this patient, would the outcome be different? And so it's important to also inform like sort of key stakeholders, and then thinking about like what would be the opportunities for measuring going forward that we can think about whether this would happen again. And then, when I worked with a team, like one of the things that we always said is sort of ground rules in these really difficult discussions. And the quality team was very hesitant to take this on. And rightfully so, they felt like they really weren't subject matter experts on bias and discrimination. They hadn't really worked much around equity, and it was an uncomfortable topic. So it's always helpful to set some ground rules. And these are the ones that we sort of standardize in our center. So when we have these discussions, is like sort of valuing the different perspectives, listening actively, speaking from your own experience rather than they or we and you, avoid making assumptions about some other person's identity, and sort of engaging in a dialogue, not a debate. It can get very heated, and it means different things to different people. And for people who don't usually talk about racism in diverse groups, this is really uncomfortable. But like I always say to people, if you feel uncomfortable, then you're having the right conversation, because it is uncomfortable. But when people sort of gloss over things, try to make sure everybody feels comfortable in the room, we actually don't get a lot done. And be open to learning, but don't ask people to teach you things that you should just learn yourself. And then I always say, share the air if you tend to dominate the discussion, or if there's a power structure in the room, take a step back. And those people that don't tend to sort of talk much, they should take a step forward. And we do this because, this is like old now, but Robin DiAngelo came out with a whole book on white fragility. And I always like this New Yorker article because it sort of sums up like, why is that book so important? But it really talks about white fragility and how that has sort of stopped us from having these really important conversations because, and so I always recommend reading that. So in the past, we've used, for like a decade and a half, we've used sort of what I would call passive use of data to look for disparities. And this is our annual report on equity and healthcare quality, where we take our data that we collect on race, ethnicity, and languages, stratify our quality metrics by these demographics. And then we have a 50-page report that we put out with the results. And then based on like where we saw disparities, we would do quality improvement projects. So it's a very long process, and it tends to look at data in the past over a couple of years. So things that have already happened, and depending on like how big your population size is for that you're looking at, you may be looking at rolling up like data in 3 years. And this just tells you like what some of the things we talked about in this report, and it's available on our website if you want to take a look at it. But this new system is really patient safety reporting, using sort of more an active view about what's currently happening in the hospital. Literally last night, somebody could have filed a report on an incident that happened in the hospital. And you see again, like sort of the process. So I feel like it's good to have both looking at sort of a data and looking sort of retrospectively, but this is more timely. Now, the end of this is smaller, obviously, but it's also more rich in sort of understanding the context, the people involved, and the impact. So what are we seeing in the reports? I'll actually stop here just for a minute to see if there's any questions. Anybody want to like raise a hand or put something in the chat? No questions. Okay. Oh, here we go. Somebody, Candace, go ahead.
Can you hear me?
Yeah.
Okay, so I was just wondering, is this reporting system only open to hospital staff, or are patients also able to report instances where they feel like they've experienced inequitable care related to their race, gender, socioeconomic status?
So patients we encourage to go with like, I can't remember the name, but the group that sort of oversees patients. So that would be a separate reporting system. Now, however, a clinician or staff could file a report on behalf of a patient, and we do see that a lot. But if a patient themselves wanted to report something, they would go sort of to the group that sort of manages conversations with patient. So they wouldn't actually be able to file the report in our system. You'd have to be an employee to be able to do that.
Okay. And is there a link between the group that interacts with patients and the quality piece?
Yes. I mean, if I'm not so sure what happens when there is like the chief medical officer gets involved if a patient files a report. And so he also oversees this. So yes, there's a link.
Okay. Thank you.
Yep. I will be honest with you though, most patients don't feel like they're empowered to make complaints, right? It's so sensitive. You're here for care and you worry about like if you make a complaint that something will happen to the kind of care that you receive. That is still sort of like a trust issue. Okay, so what do we see in the reports? Well, one is that actually what we just talked about, a patient experiences bias or discrimination by a staff member. So we see this in the report. And so what are the resources that we provide? We have a patient code of conduct, and I'll talk about that in a minute. We have bystander training and also ending racism training for the employees. So in a clinical setting, a patient experiences bias or discrimination by staff, and a report gets filed by staff. And then we provide these resources. There is also bias discrimination from staff to staff. So if a staff member is experiencing bias or discrimination by another staff member, we sort of have the ending racism training, the bystander training, but we also have this thing called concerned management system. It's CMS for short. Which actually is where these should be filed if it doesn't impact clinical care. So the problem with CMS is that it's hard to find. I have to like bookmark the link, and it was rolled out a soft launch, which basically is code for, we didn't spend a lot of like PR sort of announcing this system, and nobody's clear who sees this or what actions will be taken. So I often get reports that probably should go into the concerned management system, but people don't trust that that system works. They know that RL solution works, right? So they will file the reports in sort of the wrong area with the idea that it will be reviewed and seen by somebody, or they can't find a link. There is that, or they're unaware that we have this concerned management system. So that's part of sort of the problem. Now there can be, so what does an example look like if it impacts clinical care? That would be like if a resident felt like a nurse challenged their decision and it had something to do with their race or their gender. So that would be appropriate to file in our RL solutions, as it, because it impacts the clinical care. Like if the resident's asking the nurse to do something, the nurse doesn't do it. that impacts clinical care. The last one is there's bias discrimination from staff to patient. Now, when we put this system together, I think people felt like it would be really the other way around, right? It would be patient to staff. Hold on, I might have these flipped up. Staff to patient, yeah, patient to staff. Where, sorry, this first scenario is really patient is discriminatory things to a staff member. Sorry, I got that one wrong. And then this one is staff to staff. And this one is a staff says, you know, things to a patient. And I think people feel like that wouldn't be us. And so people are surprised that actually this is, when we rolled out the system, this was like a high number of the type of reports that we were seeing. And specifically where this sort of impacts other members of the staff is that staff or residents who witness the event. So, you know, they see that staff is sort of, you know, biased against the patient, and they witness it, and they're the ones that file the report. What we do here is ending racism training, bystander training. Again, there's concerned management system, and a case debrief if needed. So those are sort of the three scenarios. Patient is, you know, biased against staff, staff to staff, and then staff to patient. Any comments or questions? Since the launch, these have been the most common themes, and it's nothing that we didn't see in the literature. I think that was probably the biggest takeaway for me is, you know, this is on, most of the reports are filed on inpatient, so less on ambulatory care. But most of them are on inpatient, and it can be a mix of the three scenarios that I just mentioned. But here's sort of the trends that we were seeing. Bias in pain management for patients who are patients of color, or people of color, including sort of dispensing pain medication. And we've seen that in the literature, you know, where if you're Black or Latino, you're less likely to get pain medication, even if everything else, like your socioeconomic status and your insurance is the same. Definitely a bias in care for patients with limited English proficiency, and I'll give you a case example. And a bias in pain management for patients with substance use disorders. A bias or delay in providing treatment for patients of colors. And there's a huge impact for residents who are people of color, and sort of the relationship with the nursing staff, which here at MGH tends to be not very diverse. So this has been sort of an area of tension, you know, for the residents. And we've done like a great job recruiting more diverse residents, trainees, here at MGH. But part of the problem that we're facing is it's great that we are able to diversify our incoming class, but if you're still bringing them into the same system, you know, there's going to be issues. And so we've seen that. And there's a reluctance to report a lot of this for fear of retaliation by floor staff. So I've heard that definitely from trainees. And so I think what we see actually in the report is probably just the tip of the iceberg. And I've definitely had to debrief with a lot of trainees, you know, there's a power structure there as well, and sort of, you know, talk with them in sort of a safe environment about what they've seen. And most of it is me just saying, I totally believe you. I know that happens. And here's what we're doing about it. And here's where the challenges are, right? I mean, we're trying to dismantle some of the structural racism that's preceded us by centuries. We're also in a very old institution that's been around since 1822. And so there's things that are embedded into our culture that we still need to work on. And we're looking at sort of recurring trends. And what I mean by that is, you know, there could be a unit or a floor that are more likely to see these reports than others. So I thought it would be helpful to just like walk you through a case study. So just a brief summary is an elder Cambodian speaking oncology patient, which seems to be perfect for this group, was in the hospital for less than 48 hours. So he wasn't there for very long. The family members also needed assistance with an interpreter, and the patient is decompensating, and it was really unclear if it was reversible or not reversible. And the resident who filed the safety report was really concerned because they felt there was a delay in a rapid response due to the bias of this patient not speaking English. And interventions that are frequently used to buy time until the family comes into the hospital to say goodbye. The family was in Revere, it's about 30 minutes away from the hospital, such as pressors, were contested for this patient for unclear reasons, and comments were made by the nursing staff that further raised this concern. So the report was filed. I actually ended up speaking with the resident sort of separately, and then they bring a group of like sort of folks together to do a case debrief. And I think the first thing I learned, I hadn't really sort of sat on these case debriefs, is that there's a real sort of walk through the medical aspect of it, which I'm not a clinician, so it's sort of, mind blowing, but really sort of thinking that like the answers about why this resident filed this aren't going to be found in the medical record, so that was like one big takeaway. Like I think we spent like 40 minutes just going through the case itself. And then, why this resident filed it isn't really the answer is not going to be found in there. So, you do this case review with a multidisciplinary team, and, it can vary how that goes. It just depends by department, by unit. But from this case study, there was a determination that there needs to be a rapid response criteria that the entire floor or department or unit can agree on, because it was very subjective. And whenever something is subjective, it's open to bias. And of course, then people were like, well, there has to be some leeway for varying clinical procedures, but it was agreed upon that we would need to like put together some criteria. And then also just confirming that there's reminders throughout the whole floor, visual reminders of rapid response. And, our enterprise, Mass General Brigham, rolled out a sort of ending racism training and upstander training across all of the sites. And my suggestion was that they hold debriefs with the teams after their training to sort of talk about these very difficult topics with everybody on the floor. So this had a good outcome because there was something policy-wise that we could implement that could have a better impact. But in a lot of these cases, it just comes down to he said, she said. And, there's no way to prove that that person didn't say this or didn't do that. And so my role is not really to like say, yes, that happened. No, that didn't happen. My role is really to support people to help understand like, oh, this aligns with the literature that we see on disparities. And also to help with sort of education. And part of my role is to really just talk about things that most people are so uncomfortable talking about, and just naming the elephant in the room. And my other part of the role is to just talk to the people who filed the report and sort of debrief with them and, help them say, I see you, I totally understand why you filed that report. And then this is not really a surprise, right? This case study, because we do know that patient safety for patients with limited English proficiency is a problem. They're more likely to experience medical errors, more likely to suffer physical harm, and adverse events are more likely to happen. This has been documented in the literature. It's still a problem, and it's really about communication. And this is sort of a chart that we put together because I think people, with all the different modalities of how you can bring an interpreter into the room, phone, through video or in person, like people seem to not really understand, like, when is it appropriate to have an interpreter joined by phone? When do you need to have an interpreter in person? So I worked with all the interpreter directors across our system, and they all had like sort of various like guidelines, but we put together this like wonderful chart. And really it's about like how high is the risk for miscommunication. If the risk for miscommunication is very low, for example, it's just an appointment that you're scheduling, then using a phone interpreter is okay, or a video interpreter. But if the risk for miscommunication increases, so things like an end of life conversation, or if there's multiple providers, or if it's discharge instructions, then it's really more beneficial to have an in-person interpreter, or at minimum use like a video interpreter for folks, for example, who are working with children. So this just gives people a sort of a scenario of like, what are the gold standards when it comes to using interpreters? Recognizing that honestly, this is super advanced, and that for most organizations, just getting an interpreter in the visit is a challenge, right? Okay. And then that report I showed you, the annual report on equity and healthcare quality, also, this is sort of a report out on patient experience, and orange is where there's a disparity. So you can see here for patients with a language other than English, it's pretty much like across the board, a huge disparity around their patient experience about whether the provider listened, explained things at discharge, whether the nurses listened. And same thing for ambulatory care, you know, again, reception, good communication. I mean, obviously we have a lot of work to do here. It's orange pretty much in all races, but definitely also by language. So what we are seeing is sort of mirrored in our patient experience data. And I always,
Do you use a certain scale for that, or is that a Likert, or how do you measure that data?
this,
Yeah.
this currently we use a vendor. They use texting, and I'm sorry, I'm like, I have to be completely transparent. I had a bone marrow transplant in January, and one of the things it does is affects your memory. So I'm not as not quite as up, but I don't know if this specific survey uses a Likert scale, but my guess is yes.
The reason I ask is because we, as part of this project, we're using the medical discrimination scale to ask patients about their experiences, and the scoring is remarkably positive to an extent that I don't think is reflective of the actual structural bias that is embedded in the system. And so I just wondered, I think that my sense is that the instrument may be a little too blunt, and I was just looking for a potential alternative, because I think asking if actually the one item that was most negatively scored was whether they felt listened to, but the others are so kind of so negative that I think patients don't want to say their provider is something negative, you know? So
Well,
I'm just wondering.
yeah, I mean, yes, survey tools, the design of them has to be pretty intentional. So I'm happy if you want to send me the survey tool. I can also loop in one of our faculty. He does a lot of survey work to kind of take a look at your questions, and if that would impact how people answer them. But I would just say from my personal experience, like oncology is sort of a special field. And it attracts special clinicians who are very motivated in a way that maybe like general medicine is not, or, you know, and so my own experience, like if you ask me to fill out the survey, it's been wonderful. And so maybe that's part of what you're seeing, is that you have such a field where people are just grateful, but clinicians are also really great. So I don't know how this would look. I'd have to look how this would look if you just separated oncology.
That's a good point. Yeah.
Yeah, this is everything,
Gotcha.
right? So this is the good and the bad. I bet you if we looked at surgery, it would be very different versus oncology. That's my guess, you know. So
No,
that might be what you're seeing.
that's helpful.
But I'm happy to look at the survey. So if you want help with that, just send me an email.
Sure.
Okay. So I always love, and thank you for that question, Mandy. I always love this thing, which I should take the year out of this. But they stopped kind of doing this, but I think it tells you a lot. So the question is, they asked, I think, about 60,000 physicians. It was survey, so self-reported, like which patient characteristic triggers bias. And then this is what people listed, and this is broken out by gender. And I always like to point out that while race is at the bottom, which really sort of is a reflection of what people think is appropriate to answer, language is one of the top, and they were equivalent for both men and women. And so this really tells me that, like, what you're saying is if a patient comes in and they either cannot speak English or they have a heavy accent, that it triggers bias. And so that case study is probably, you know, you can see how this all ties together. Like all the data sort of supports what this trainee was saying. So what are some of the resources that we can provide? I'll just wrap up here. We have a code of a patient family visitor code of conduct. And this was really aimed at, like, the patient says nasty things to the staff, right? Like things like, you look like you come from China, or I don't want you to be my provider. And sort of, there was a lot of work that went in here to sort of have this outline to patients saying that we're not going to tolerate this. You know, it's stressful enough, but without this added layer of discrimination, you know, here's what we're going to do. And I think that was very helpful to sort of talk through, like, what are the scenarios? What are we doing? And so they put this patient family visitor code of conduct together, and it was based on the SAFER model. And this is sort of the rationale, and I'll make sure to send the slides afterwards. And then this is sort of what's communicated to the public, right? Which is slightly different than what we have internally. There's also upstander training and ending racism training, which I thought was done very well. Basically what they did is they did focus groups across our system, and then made sort of case examples by the stories that were told during the focus groups. And as a learner, you had to go and choose different scenarios. So it was very interactive, and I think it was really well done. Slightly triggering for some of us, but I thought overall it was a really excellent training. So I would just say, in summary, you know, you have to think about community mistrust when you think about filing the safety reports. You have to think about language barriers and immigration issues, and sort of the bias of, you know, who we deem non-compliant, and the idea that we have this bias that idea is only one single diagnosis, and thinking about, like, who do we screen for social determinants of health, and who do we initiate a rapid response for or care. And so having policies or checklists in place helps remove some of that subjective bias. But policies only work if there's a deliberate implementation on the floors, or in the practices, or across divisions and departments. And I say this with that patient's code of conduct. You know, when I bring it to people, they're like, oh, yes. But how do I talk to the patient, you know? And so that's where I say you guys have to have, like, a conversation as a team. Like, if this scenario happens, who's going to do what? Like, what is the process for that? Just having something on paper is not enough. You have to kind of talk about it with the team, so that you're prepared for when it does happen. And as I said, answers to why somebody reported bias or discrimination will not be in the medical chart, but everything we see in the reports has evidence in the literature. And this one is a big one. What people will say is, well, I didn't intend for that to happen, or that's not what I meant when I said that. And while that is valid, you do have to sort of consider the optics of the person to whom you said it or to whom it happened. You know, that should not absolve you from anything. Like, the conversation cannot stop with, like, well, I didn't mean that, you know, and oftentimes it does, right? I think it's an opportunity to sort of understand the impact of your own words or your own actions that were unintended. And I actually think it's always a gift when somebody gives you that kind of feedback. And it really comes down in my eyes to sort of the importance of a diverse team. And I don't just mean racially diverse, although in this country, it definitely comes down to race a lot. But really like understanding, like having somebody on your team who has lived experience, meaning they understand what it's like to be hungry. They understand what it's like to be poor. They understand what it's like to couch surf. You know, they understand what it's like to have, you know, experience domestic violence, like, or have addiction. Like you have to have team members who have that lived experience, because that will provide better care to these patients that are coming in. They come from a very different perspective. And I think that's something we at MGH need to work on. So this is my contact information, and I encourage you, if you have any questions, to always reach out. We have a website, which I didn't put on. Well, we have a Facebook page, and we also have a website, just if you Google our center's name, and happy to answer any other questions that you may have. I'll stop sharing.
Thank you so much. Oh, Candace, go ahead. I have a new puppy, so he's sleeping.
Oh, so I was wondering, you spoke about the patient and visitor code of conduct, and how the initial thought was that most of the incidents that would be reported were going to be from patient to provider. I'm wondering, has there been any consideration to having like a staff code of conduct, since you're seeing that there are a significant amount of incidents that are being reported from staff to patients?
Yeah, no, I mean, Candace, totally legit question. And I think this is a tough pill to swallow. I think, you know, just think about your own institution, if that would go over well. I think we all like to think, not me, right? Not us. And the truth is, you know, it is us. It's all of us. And we just have to work really hard. So no, there has not been sort of this movement to sort of think about, you know, having something reversed of that patient code of conduct. I think the patient code of conduct honestly happened during the pandemic, and the driving force was the big burnout that clinicians had from just like, you know, COVID, and then, you know, all the things that were happening on the floors, and, you know, the racism that was happening, and it was really impacting our workforce. So I think that's part of the driver for that. But yeah, it would be good. I mean, I think that's the training sort of to a certain extent, you know, ending racism training, that it was mandatory, so everybody had to take it. I think that's part of that, like, changing of the culture. But honestly, I think that really, if we were going to make these changes, you know, there's a lot of different changes that we need to make, but I think one of them would be to really diversify our workforce in all levels, like not just, you know, physicians. It needs to happen in nursing staff, you know, it needs to happen in middle management. Like that's where a lack of diversity is in our institution. So that, I think, would be sort of the solution. And then the ability to have the conversations that are very difficult in a safe space. I think that's kind of missing. You know, it varies, depends on like who's on the unit, you know, how comfortable they feel themselves. So I will tell you, when I was in the hospital, I was in the hospital on the unit for 16 days, in the bone marrow transplant unit in January. And you know, you get to know a lot of the nurses, and apparently they get to sign up for whatever patient they like. So I had like 4 nurses that were like sort of constant rotation. And it was very interesting. Once they knew that I worked at MGH and what my role was, I had a lot of really good discussions with nurses, like in the, you know, 6 a.m. when they wake you up to draw your blood, or, you know, during the day, about D&I and just sort of their own experience, and talking about, like, you know, they had like a new nursing director and she was great, but the previous nursing director just hired a lot of white nurses, and how did they make them feel? And I just had this sort of like realization that like really all they wanted was the ability to talk about some of these challenges. And one of the nurses told me, she's like, when I saw that you were a patient of color, I was so excited, because most of the patients on the floor were older and white. So that's kind of like our challenge, right? Is it's about being able to have these conversations about things that bug you on a daily basis and not feeling like you can talk about them. And so it was kind of eye-opening for me. I was like, we set the bar really high, but honestly, like, even if we just did this, like if we created a safe space to talk about these difficult issues, like that would go a long way making staff feel like they were seen, they're valued.
Thank you. Any other questions from folks? This was really helpful. I'm sorry, we had a little bit of a Zoom mix up at the beginning, so appreciate Annie introducing you. Anyone else have any questions?
I guess I'll ask another question if no one does.
Yeah.
Go for it.
You talked about having debriefs after people did the training that was rolled out across the institution. I was wondering if you could talk about like how those debriefs went.
Well, the debriefs were really not after people rolled out the training. I encourage people to do debriefs with their staff on the floor after everybody took the training, and I was always available. I don't know if that really happened, to be honest, but in sort of talking with a lot of my peers who took the training, especially people of color, you know, everybody was like sort of surprised at how well done it was, because we've all had these like e-learning trainings that were just sort of, you know, check the box. And this one was very thoughtful. But the downside of those trainings was that people were like, you know, I had to go home and like have a drink because it was so triggering in many ways. Like for maybe the white person, like this is a surprise that these scenarios happened, right? But for somebody like myself, I could recognize every scenario that they put up. I was like, yes, that happened. Yes, that happened. And there's something freeing about that, but also something like really it takes an emotional toll. And then the next step would be to kind of have a conversation with your team. Like, how did you feel about those trainings? Did you think they were helpful? Was there anything new? And I think that piece is really missing, because that's the first baby step to having conversations about a topic that is really hard. So I would say probably most of what happened across our system is everybody took this training. You know, some people were enlightened, some people were triggered, some people didn't care. They just tried to get through it. And that's where it ended, which is really, to me, very sad, because it's an opportunity to do more.
Was this a training that was built in-house, or is it accessible?
Yeah.
Okay.
Yeah. I don't know how they did it. I was very skeptical, but I will say I was very impressed. And so maybe would encourage you guys, you know, if you're going to do a training, basically they did focus groups and they brought up scenarios, and then they had sort of an interactive where they would put the case module up and they did some interactivity of like, you had to pick a scenario and then follow that scenario out. And it depended on who you were in that role, whether you, like, for example, you were the physician, the attending versus the resident, or the nurse versus, and then they also had one for administration, which I thought was good, because we tend to focus a lot on the clinic piece, but there's also the administration or research, right? For example, in our institution.
That's great. Yeah, we did have folks do an implicit bias training that was case-based. It wasn't, you didn't navigate options exactly, but you saw kind of role play in various scenarios. And we had we've had 419 people take it across the 3 institutions. But I mean, these are obviously, you know, layers that need to happen, you know, like it's not a one and done, but.
Yeah, exactly.
Well, thank you so much for your time today. This was really helpful. And we have all of our sessions archived in a toolkit. That's a webpage that we make accessible to whomever, you know, wants to use those resources. So we will have this up on our page as well. And you're welcome to direct people there to the other webinars or to your own, but we really appreciate your time, and I'm sure that we'll be in touch with additional questions. So thank you for making yourself available and walking us through this important work.
Great. Thank you for
All right.
inviting me.
All right. Thanks all.
Take care. Bye.